They were calling some towns. Yeah,
we called it
we got that's as big as it'll go.
Okay, can you hear me? Okay, I guess we'll get started. I'm Steve Campbell. I'm Vice Chairman of Urology here at the Cleveland Clinic, and we're very excited to host this event. This is part of Men's Health Month, and the main goal here is to try to improve awareness about men's health. This is called our Drive for Men's Health, and we have a few special guests that I'll introduce in just a second, but this is a wonderful event that includes a drive across the country, 6,000 miles in 10 days, which is stopping at 15 major medical centers and across the country, again, to improve awareness about men's health. And as part of today's event, we'll have 3 talks on various men's health issues, voiding issues, testosterone replacement therapy, and also prostate cancer and PSA screening. So just briefly, a few things about our department. We're a large department, and we have a wonderful group of physicians and surgeons and ancillary team members that work very hard, and we've been honored over the last few years to be named #1 in urology and #2 in nephrology by U.S. News and World Report, which has been wonderful. We have over 71 physicians and scientists, and we are very, very busy across the region here with over 60,000 outpatient visits and over 14,000 surgical cases. And again, very excited to be #1 in urology, and our training program here, our residency training program, also honored to be #1 rated in the program in the country. So we have many centers of excellence here in the urology department, and one of them is Men's Health, and we'll be introducing some of our Men's Health leaders in a few minutes. We have multiple sites across the region, and if anyone here would like to make an appointment, just let us know, and we can make an appointment here at the end of the event. So without further ado, I'd like to bring up Sijo and Jamin to tell us a little bit more about the Drive for Men's Health.
Thank you so much. So thank you for coming out and supporting us, and we look forward to really partnering with the Cleveland Clinic. I have a soft spot for the Cleveland Clinic. I did my fellowships here, so I'm always definitely loyal to the Cleveland Clinic. But The whole goal of this event was, Orlando Health did a survey recently where we surveyed 1,000 guys and asked them two simple questions. Do you remember the name and model of your first car? And the second question was, do you remember when the last time you went in for your doctor's visit was? And what was surprising is that, we probably kind of knew, over 80% of the guys knew everything about their first car, but less than half of them remembered when the last time they went in for their doctor's visit was. And that really is discouraging in terms of, why is it that for men, we just don't take our own health very seriously? Well, how do we make it more fun and exciting? And that's how this whole event came about.
And statistics, that was just one small survey. If you look at statistics, in 1920, the life expectancy gap was only 1 year between men and women. Now it's 5 years. If you look at the top 10 causes of death in the United States, let's take a survey. How many of you guys think it was 5 out of 10 is what men are most likely to die of? 5, 6, 7, 8, 9, or 10? 9. So 9 out of 10 top 10 causes of death in America, men are more likely to die of. Men's health is definitely in a state of crisis, and I think this was an awesome place to visit, because walking down any hallway, you see this is Men's Health Month, Men's Health Month, Men's Health Month. You're getting the message out. So I'm so glad to be partnering up with you guys and being here to be a part of the message, which is we need to change the statistics of men's health, and we're doing it with this car, with the technology, and basically trying to get guys to talk about their health and take it seriously.
So with that, we really look forward to having local drivers or champions, and looking forward to the Cleveland Clinic as being a partner here to promote men's health awareness and interest. And we look forward to many more years of collaboration and doing some fun events. With that, I'm going to hand it over to Dr. Campbell, the Vice Chair of the Urology Program here at Cleveland Clinic.
And if you guys have any, we actually have a live webcast at driveformenshealth.com, so if you have any friends or family that couldn't make it, please just let them know they can watch all these activities now, and then it'll be chronicled on our website afterwards. Thank you, Dr. Cope.
Okay. Thank you, Jamin and Sijo. And our first speaker will be Rob Stein, and Rob will talk about prostate cancer screening and the use of PSA. So just 1 second, we're going to switch out the computers.
I don't know if everybody can see the screen. Okay. Oh, thank you. So I'm Rob Stein. I am the co-director of robotic surgery here at Cleveland Clinic, and I do a lot of work with cancer as well as minimally invasive surgery. So thanks very much for having me, especially Sijo and Jamin, and this is a wonderful program to be a part of. It's growing, it's in its second year, and it's just taking off like wildfire. So I was asked to talk a little bit about PSA screening for prostate cancer, and some sources will have you believe that prostate cancer maybe isn't that dangerous. Prostate cancer is slow growing. Not all men who have prostate cancer die of prostate cancer. But on the contrary, prostate cancer is the most common non-cutaneous cancer in men. It is the second leading cause of cancer deaths as well. So it's a significant issue. 20% of men will be diagnosed with prostate cancer during their lives, and a significant amount of these will actually die of their disease. So one of the big breakthroughs was the discovery of PSA. This was in the late 80s that PSA screening started. And what it has led to is a significant, a 40% decrease in deaths from prostate cancer, and a dramatic decrease in the incidence of metastatic prostate cancer. So we talked a little bit already about why to perform prostate cancer screening, but then the question is, how do we do it? And also a very important question is when, at what age do we do it? How frequently do we perform the screening? It's a little bit more about why we perform prostate cancer screening. There is, with prostate cancer screening starting in the late 80s, there has been a much higher likelihood of detection of prostate cancer. So here you can see after 1990 that there was a tremendous spike in the amount of prostate cancers that were diagnosed. What this equates with is a much earlier diagnosis of prostate cancer. Essentially, it's easier to cure prostate cancer if we catch it in time, if we catch it early before it spreads or metastasizes. On the same theme, a lot of men will come in to me and they'll ask, Doc, is my prostate cancer still encapsulated? Is it still confined within the prostate? And you can see here that before prostate cancer screening, almost 70% of prostate cancers had essentially progressed to leave the prostate capsule and become a little bit more aggressive. Several years later, so most likely due to PSA screening, now less than 30% of prostate cancers have now become more aggressive. So what about survival from prostate cancer? Probably the best study was from the Europeans. They looked at 180,000 men. Half of these men were randomized to getting PSA screening. Half of the men didn't get any screening at all. What they found was that there was a 20% decrease in the risk of death from prostate cancer. So we really have great tangible evidence that PSA screening very much, or most likely, does help in terms of saving lives. Now, how do we do prostate cancer screening? We do the digital rectal exam, and we also check the PSA, which is the blood test. The digital rectal exam, with the digital rectal exam, we feel the prostate and we discern if there are any nodules or hard areas on the prostate. Those would likely mean that there is a prostate cancer tumor in the prostate. Now, in terms of the PSA test, the blood test, we used to say that if it's above 4, it's abnormal, it's concerning for cancer. If it's below 4, then it's normal, nothing to do. But we found that over time that actually there is no more 4. We say 4 no more, because we found that even in patients with extremely low PSAs of less than 1, there is an 8.8% chance of finding prostate cancer on a biopsy, and with a PSA of 1 to 2, even a 17% chance of finding prostate cancer. So essentially, when we look at the PSA, and when your doctor looks at the PSA, it's really a kind of a spectrum. The numbers that we look at. We don't look at a particular number as being normal or abnormal. Now, there are other approaches that your doctor can use in order to look at the PSA, other variations like the PSA velocity or density, and other assays like a urine assay called PCA3 that your doctor can use to help a little bit better nowadays with determining if you're at high risk for prostate cancer. So one of the very controversial issues nowadays is when to perform PSA screening. So the concern is that there are a lot of benefits most likely with PSA screening, but also there are risks. Like if we do more prostate biopsies, then there is some incidence of having infections, and also we might diagnose more less aggressive cancers that may not be important in terms of the lifespan of a man, that may not progress to metastatic disease within their lifetime. So those are some of the risks or issues with PSA screening. So recently the U.S. Preventative Task Force suggested maybe to even never screen for prostate cancer. Now, as doctors and most doctors, almost all urologists, we think that that's a bit of an overreaction. So some of the major societies have come up with guidelines that are newer and maybe a little bit better or more pragmatic than our old guidelines of just checking PSA once a year after the age of 50. So I think some of the nice ideas with these new guidelines are right here, maybe considering semi-annual or even less frequent screening, so every 2 to 3 years. Maybe that's going to be just as good as checking the PSA every year. I think that's a reasonable option now. Also, the Europeans suggested doing an early baseline PSA, maybe at the age of 40 to 45. If the PSA is greater than 1 at that point, then we should probably follow a little bit closer the PSA. If the PSA is less than 1 at a young age, then maybe we should we don't need to follow the PSA quite as much. This concept comes from this European study where they found that for PSA of 0.9, of greater than 0.9 or even greater than 1.6, the likelihood, and this is at an early age, this sort of baseline PSA, the likelihood of having metastatic disease is significantly higher over the next 25 years of the man's life than for a very low PSA or baseline PSA, where the likelihood of having metastatic prostate cancer is extremely small over the next 25 years. So if your urologist feels that you have a concerning PSA, something that looks high risk for having prostate cancer, he'll probably suggest to have a biopsy so we can get some tissue to figure out if there actually is prostate cancer. So in conclusion, prostate cancer screening has led to earlier diagnosis, has led to saving men's lives over the years since its inception in the late 80s. There are concerns of overdiagnosis and treatment. So I think that we should have a pragmatic approach of doing maybe a baseline test, less frequent PSA checks, perhaps every 2 to 3 years, and screening only of men with greater than a 10-year life expectancy. So thank you very much. I appreciate it.
Okay, I think we're going to do questions and answers at the end of the 3 talks. And one other important thing, Rob, is for men to know is if you're diagnosed with prostate cancer in this era, it doesn't necessarily mean that you have to have surgery, that you have to get treated. We look at the aggressiveness of the cancer and we help you decide whether you want to get treated. But, more information is always better. And it allows us to make smart decisions, and it allows us to treat the more aggressive cancers in an effective way. And this really does save lives. So it was a great talk. Thanks, Rob. So our next speaker is, thank you, Charlie Modlin from Urology and Renal Transplantation. And Charlie is going to give us a nice overview of something that a lot of men struggle with as they get older, and that's benign enlargement of the prostate, and it starts blocking off the urine flow, causing urinary symptoms, and this is a very, very common problem for men. So once we get set up here, Charlie, thank you for helping us out today.
So good morning, everybody. I'd like to thank you for allowing me to be part of this great event, and thanks for making Cleveland Clinic part of one of your pit stops.
I'm going to be very brief because I know you have to be in Detroit, I think, by 11 o'clock. So you don't want to break any speeding records. So we're going to get my slides up here. I'm going to talk about something, can we see? Okay. That actually afflicts a lot of men and is a reason why a lot of men actually present to the urologist. Benign prostatic hyperplasia and voiding dysfunction in men. I don't know, do you recognize me here? That's my contact information if anybody would like to get that. I tell my kids all the time I'm going to grow my hair back out like that. I probably couldn't even if I wanted to. So basically, some causes of voiding dysfunction are related to conditions other than the enlarged prostate. But by and large, most men that present with voiding dysfunction have that voiding dysfunction as a result of an enlarged prostate. We call it BPH. There are secondary causes, primary bladder dysfunction, stroke or neurologic causes also can contribute to voiding dysfunction, diabetes, medication, and infection. But I'm going to limit my talk today on problems urinating that many men have that are related to having an enlarged prostate. As men age, the prostate actually has a natural tendency to enlarge, which can obstruct the urethra and make it very difficult for the individual, the man, to empty his bladder effectively. Inability to completely empty your bladder actually can cause what we call urinary retention. It can lead to urinary tract infections, kidney disease, and other problems of the urinary system. This is just a diagram of the normal prostate, and this is a diagram of an enlarged prostate. You can see this is the bladder, and the urine empties through the urethra. And so if the prostate is enlarged, you can see there's the funnel, the urethra is actually narrowed, and it makes it more difficult to completely empty the bladder. I want to talk about some of the most common symptoms that men may have, which could be signs of having an enlarged prostate. One of the most common symptoms we have is that we see is that men may have difficulty starting urination. We call it urinary hesitancy, and again, it's because the prostate is enlarged and it makes it more difficult to mount a pressure strong enough to expel the urine. Again, inability to completely empty the bladder actually can cause urinary retention, which could be a medical emergency because it can lead ultimately to kidney damage and even kidney failure. Intermittency is another common symptom or sign that men present to the urologist complaining of, and that basically, intermittency just refers to having to stop and start the urinary stream. A lot of times the guys start urinating and then it just cuts off, and they have a lot of difficulty and it causes a lot of distress. And so what men try to do oftentimes is they have to strain and try to force more urine out of their bladder, and that straining can actually lead to further problems. A lot of times we have men presenting with what we call low flow or low urinary stream, and that just represents another condition caused by the enlarged prostate, where it takes a prolonged period of time for the man to empty their bladder. So again, it just because of the enlarged prostate allows only a small amount of urine, and it results in a weak urinary stream. That's one of the most common presenting signs. Terminal dribbling, which is just another terminology to represent that when the man finishes urinating, a lot of times he'll have a little dribble out that he doesn't know that is still there. And it can be very disconcerting because his underwear may actually become wet from the terminal dribbling. Urinary urgency can be another sign of an enlarged prostate. Oftentimes men actually have to suddenly urinate. They get a sudden urge to go urinate, and that is very distressing to a lot of men. Nocturia, which is, we define nocturia as having to get up to urinate 2 or more times per night. It interrupts the gentleman from his sleep, and again, resulting from the fact that the enlarged prostate inhibits complete emptying of the bladder. Some of these symptoms and signs, as I said, most likely are attributable to having an enlarged prostate, but there are other conditions that can contribute to some of these symptoms other than urologic problems. Straining to urinate is another common symptom that we see. Prolonged straining actually can cause injury to the pelvic floor, cause hemorrhoids and other conditions that can be a major problem. And urinary retention, retaining a large volume of urine in the bladder can be very troublesome. These are extreme cases where gentlemen can actually develop bladder stones and even kidney stones. Obviously, many of these conditions require further urologic intervention. A lot of these stones form as a result of retained urine and urinary tract infections developing. We can actually also see acute kidney injury causing kidney failure from the obstructed prostate and urinary retention, where if the bladder is not able to empty, you get back pressure up into the kidneys, which can be a major problem and a source of causing kidney dysfunction. An enlarged prostate actually can contribute also to erectile dysfunction, which concerns many men as well. And one of the things I wanted to point out is that some of these symptoms I talked about related to having an enlarged prostate can mimic symptoms of prostate cancer, but the main take-home message is that most men with prostate cancer actually have no symptoms whatsoever. And falsely, a lot of men think that if they don't have any symptoms, then they don't need to be screened for prostate cancer. But Dr. Stein talked about the importance of screening for prostate cancer. There are many treatment options for having an enlarged prostate, BPH. Men don't have to suffer the symptoms or side effects of having an enlarged prostate. There are things that can be done to improve the condition. There are how we choose what type of therapies really depends on the individual patient, depends on how much the symptoms are interfering with the normal lifestyle of the individual, the size of the prostate, the age and overall health status of the individual also are taken into consideration when we plan how to treat the condition. First line therapy generally is reducing fluids at night, but then medical therapy with alpha blockers is something that most urologists will consider first line therapy. These are some of the most commonly prescribed medications: Uroxetrol, Cardura, Rapaflow, Flomax, and Hytrin. And these are very effective in many men, but in many situations the medications are not effective. Sometimes we'll use alpha blockers in combination with 5-alpha reductase inhibitors. The mechanism by which 5-alpha reductase inhibitors work is to interfere with testosterone metabolism, which causes the prostate.
Medical therapy for that, and there's been a number of myths, old myths and new myths. So Dan, thanks for helping us out this morning.
Okay, thanks very much. Do you know where my slides are? So there are a few areas in men's health that are more controversial and poorly done than the management of low testosterone and testosterone replacement therapy. Since people started doing it, there have been many myths, both old and now with some new very controversial data, they continue. And I just want to briefly touch on 5 of them. So the first myth is that low testosterone is a disease that has to be treated in everyone. Absolutely not true. There's a wide range of testosterones that are normal, and we see many perfectly healthy men who are older, have a testosterone check for some reason, and the number is low. No evidence whatsoever that they need to be treated. There are a few very specific circumstances, men with AIDS who have weight loss. There can be benefit. Some diabetics, and recent data published by our department suggests that men with renal failure who have low testosterone have a shorter lifespan, and treating them may be a benefit. But in general, just because your number is low, it doesn't mean that you need to be treated. The problem is, once you get started, treatment is for life. And we see many men who've been started, they don't know why, they're 5 years into it, they've spent thousands of dollars, and there's no evidence for benefit. On the other hand, there's a very pervasive myth based on the recent FDA position that low testosterone is just natural and it never needs to be treated. There clearly are some men who have low testosterone that affects their quality of life. Multiple symptoms can be associated: severe fatigue, loss of libido, depression, erectile dysfunction. Obviously, these things can be caused by other problems, but they can be caused by low testosterone as well. In order to be treated appropriately for low testosterone, you need three things. One, you need to have the symptoms. Without the symptoms, there's no treatment. Two, you actually need to have a low testosterone. So taking someone with ED and fatigue and a normal testosterone and giving them more is not going to help. And the third most important thing is once you treat them for several months, there has to be an improvement in those symptoms. So if these symptoms don't improve with treatment, there is no value in continuing. But clearly, if you have those three things, there can be a huge impact on quality of life for men. The third myth is that testosterone causes prostate cancer to develop and to spread. We're talking now about testosterone replacement therapy. This is based on the fact that prostate cancer cells do need testosterone to grow. However, they only need a little bit. And the amount of testosterone in a typical man we see who has a low testosterone value in their blood is more than enough for any prostate cancer cell in their body. We now have a mountain of data suggesting that men with previously treated prostate cancer, it's completely safe to treat them with testosterone. There's even one study showing men with untreated prostate cancer, if they're treated with testosterone, it doesn't grow, it doesn't spread. So this should not be a barrier for the appropriate symptomatic man to have treatment. The fourth, that anyone who watches local news will see a lot of ads for from local legal companies, is that testosterone replacement therapy causes heart attacks and strokes. There were two high-profile studies about a year ago. They were not clinical trials, they were statistical manipulation of existing data that suggested an increased risk of heart attack shortly after starting testosterone. These were absolutely wrong. Invalid analyses. Over 100 medical societies have called on JAMA to withdraw the one article, which actually ended up mistakenly including over 300 women in their analysis. This contradicts about 9 studies done prior that shows testosterone replacement therapy actually reduces the risk of heart attacks. And since those studies have come out, there are 2 properly done trials. They're not published, they've been presented at meetings, again showing that testosterone replacement therapy reduces the risk of heart attacks and doesn't increase. Finally, the fifth myth that we patients who've been treated is that this is actually completely safe. And despite the fact that it doesn't cause prostate cancer and it doesn't give you a heart attack, there are risks, and it must be given safely and appropriately with monitoring. There are very good guidelines published by at least 2 international societies for how to give it, what dose, what target, and what blood work. Unfortunately, that's followed in the United States probably less than 20% of the time. There is a risk of blood clots and heart attacks if the blood thickens, but you can find that with a simple blood test that most men don't get. In conclusion, low testosterone itself is not a disease. But low testosterone can cause the disease or the disorder of having all of these symptoms. Testosterone replacement therapy, when given following guidelines, can be done in a safe and effective manner, as we've done for thousands of men. Thank you.
Thank you so much, Dr. Shashki.
So yeah, if Sijo and Jamin could come up, and
So if you
also,
guys, You guys could all, we're going to do a Q&A
Okay,
down
great.
here. Whoever spoke or any of the other faculty want to join us, we usually do an open forum Q&A, and what we start off with is our social media questions. So we've been tweeting and Facebooking, and Dr. Shosky, Sidjo had a claim to fame today that he beat you to posting pictures. Oh, have a seat, Sidjo. So we're on our social media feed, and one of the questions, and we get this question every stop we go, is the question was, my husband is 40, his uncle had prostate cancer, and I'm so confused, should my husband be getting screened this early? And I know there's a lot of different guidelines. What do you guys usually recommend should be how this female should approach this?
Well, there's many controversies when it comes to prostate cancer screening, but when there's a strong family history, we in urology still strongly believe that these patients should get screened probably about age 40 or 45 with a PSA and a digital rectal exam. If their PSA comes back really low, less than 1 or less than 0.5, then they probably don't need to be screened real frequently. If I was that patient, I'd probably get checked out about age 40, and if it was low, maybe 45, 50. If the PSA started drifting up, maybe more frequently. Charlie?
Yeah, there's even recommendations for screening, especially in African American men, because they have a higher risk for developing prostate cancer. African American men, we believe, should start screening at the age of 40. Again, there's some controversy, even without the strong family history, just because of race. And again, the frequency of the screening, I think some of the recommendations now are every 18 months to 2 years. It really varies. But it's important to know your family history, but also race is a factor as well.
The next question is, I have all the symptoms of low testosterone, but my doctor won't give me won't prescribe me testosterone. That's the question. It seems like the numbers are normal, but they're having all the symptoms. Dr. Shosky, do you mind expanding on that?
Sure. Well, again, the symptoms that we discussed for low testosterone can all be caused by other things. There's nothing specific for that. And at least from the published trials, if your testosterone is above 320 on the total number, there really is no demonstrated benefit. Now, if you get treated with testosterone, you may feel an energy boost, you may build up some muscle, but that's not treating a disease, and certainly that's not a way to treat depression. Most men with erectile dysfunction who are older and have vascular risk factors, testosterone is going to do nothing to give them a harder erection. It'll be caused by vascular issues. So you really need the three things: symptoms, an actual low testosterone, and then clinical improvement with treatment.
And one question, sorry, go ahead, sir. One question that Sidjo and I always ask is, how do we get guys motivated? I mean, we've talked about the statistics. We do events like this. We have the Tesla. We have all these campaigns, awareness campaigns that you have down the hallway. But as guys, we're still lagging behind. 5-year gap between men and women. We are 9 out of 10 top 10 causes of death in America, are related to men. How do we engage men and get them motivated to essentially go see the physician and get the routine preventive screening that is so necessary and vital?
Well, I would just say that I think the American public has been sent very much mixed messages about prostate cancer, that maybe it's not as serious as we once thought it was, but we're still losing 30,000 men a year. It's one of the major causes of death for American men. So these kinds of events are really important to get the message out there that it's still very important. And, from a urology perspective, we really believe that we are saving lives with prostate cancer screening. And, just because you're screened doesn't mean you're going to end up with surgery or whatever. Again, if you're diagnosed with prostate cancer, we can help you make smart decisions about how you should be treated, depending upon how aggressive the cancer is. So I think education and public awareness in these types of events are really important.
I think we also need to be creative in terms of how we attempt to engage men with these health messages. And over the years, we found that sometimes we have to use surrogates to deliver the messages that we're trying to deliver. Perhaps going to women. Women a lot of times are making the health-related decisions for their families. Partnership with the media is very important as well. And also, we need to start educating young boys at early ages so that they know when they come of age what they need to be screened for as well.
So I think, you know, for the viewers online, you know, the whole emphasis of this event is really to try to promote guys to start thinking about, you know, if you think about how we take care of our cars with our routine checkups, you know, we change the oil when it's time, before there's a problem. And the whole idea is to make sure that we start to create the same double take for guys, that, you know, if we spend that much effort on our cars, let's try and make a little bit better effort with our own bodies.
And, you know, continuing with the car analogy, when men develop erectile dysfunction, even at a young age or at an older age, it is, we call it the dipstick for the heart. It will very often be a sign of vascular disease elsewhere in the body. So a man, if you do develop erectile dysfunction, it's not just you're getting older, well, maybe you're not that interested in sex, it's not worth signing. It is a warning sign, not just for your sexual health, but for the health throughout your body.
So everything that was talked about here, all the presentations will be archived, they're recorded on the website. Please stop by our website, driveformenshealth.com, and we'll put the contact information for the physicians here as well. The key thing is to reach out for help, make that appointment, come in to see your doctor, and we're hoping we'll continue this every year and only get bigger and better. And what we'd like to do at the end of each stop, what we'd like to do is do a group photograph. So if we can ask everyone to kind of gather right around the car for a quick group photograph, that would be great.
And before we take the picture, thank you so much, all the physicians here at the Cleveland Clinic, for being our local drivers here in Cleveland. And I hope LeBron brings it home tonight, or at least evens it up. So I'm excited to follow the journey. But thank you guys so much. And then we're going to count to 10. Everyone needs to gather on and take quick pictures. So 1, 2, 3, 4. They were much faster in North Carolina, guys. Come on. All right, so we're going to take a few pictures here.
Orlando, Dodge, Chrysler, Jeep, and Ram cleared off this lot.
Take the radio. All right, guys, we're going to take a few pictures here. We're going to take a serious picture. We're going to show Cleveland's muscles in the second picture, and then we're going to say something special to everyone out there in the third picture. So we're going to start off with a serious picture. Do we have everyone in there, or do we all need to?
I got everybody in here.
All right, now I want Cleveland to show their muscles. Everyone flex their muscles, because it's about men's health. As strong as you can. Ready? 1, 2. And then what we want everyone to say is, on the count of 3, Cleveland Clinic drives for men's health. And we want everyone in LA, we're about 4,000 miles away from LA, we want everyone in LA to hear what's coming their way. So on the count of 3, Cleveland Clinic drives for men's health. 1, 2, 3. Cleveland Clinic drives for men's health. Oh my God. They were louder in Orlando, Florida. Guys, let's try. Let's try one more time. 1, 2, 3. Cleveland Clinic drives for men's health. Thank you guys so much. We're going to stick around with the car here and take pictures. Thank you for this wonderful opportunity, and we really appreciate the support that Cleveland Clinic and all of its physicians and team members have given us. Thank you guys.